Congratulations, Dr. Ajoy, for being the first surgeon in India to do the episealer surgery. What was your experience, this being your first time with episealer?
Oh, this was extremely good. So it was much better than what I actually thought it would be. Because even to begin with, I was actually not very certain as to what we're dealing with, and because since it's a patient who was less than 40 years of age, I was hoping that we have some kind of a mechanism or some kind of a procedure which will suit him and does have some amount of a long-term study and a long-term follow-up, so that the patient does not develop any degenerative diseases. So when I came across this and got to know that we already have a episealer available and we have something which can be made specifically for this patient, I was very impressed, and the surgery itself was extremely good, with Professor 𝗍𝗵 being there, guiding through. It was excellent. And
tell us something more about the patient. How the patient came to you? What kind of symptoms the patient had, and how you managed, conservatively for some time?
Right, the patient actually came and referred because he had this problem for almost 3 years or more, and it was a gradual process. He had started having an injury, and following that he had developed pain, unable to perform his daily activities, and it was affecting his work also. So that's exactly when the patients come home. It's been 3 years, he has seen multiple doctors, not been able to get the right kind of treatment for it. Maybe there wasn't any right kind of treatment for it, and so when this opportunity came through that we can perform partial replacement, which is again specific to this patient, I latched onto it and went on with it.
Professor, how do you find the osteotomy guide useful for the placement of this product?
Well, I'm extremely happy about it, because in my own experience, and I think that of others, is that the osteotomy is not a simple thing to do if you want to do it properly, because you need to get in at exactly the right position in the corner between the medial malleolus and the plafond. And the osteotomy guide allows you to do that with great consistency. And so it's just it's an extension of our patient-specific way of thinking that I think has proven very nicely. Wouldn't you agree?
Yes, I do. Because whenever we are reaching out to the medial part of the talus or the posteromedial part of the talus, it's the reach that's the difficult part.
Yes.
So yes, so we have an osteotomy which is pre-planned, and we also know that we're going to fix it back in the same position. So
yes.
It's excellent, and the approach is done, and the non-union of the medial malleolar osteotomies, which can sometimes happen if you don't fix it well. I think that is taken care of by a patient-specific guide, which was there with this particular system. That was good. And Professor, in your thing, so this has been done for almost 15 years now?
Not quite 15, but we've done it for 11 years. Okay. Our first patient was operated about 11 years ago.
Okay.
He's still working, still walking.
Okay. Right. So any instance of it forming, like maybe like syncing of the processes happens, or any say, like we used to call it that of the total hips also?
No, what we see, we've done, or we haven't done, but we know about half a dozen arthroscopies being done after the implant is being put in.
Okay.
And we can see that the cartilage is coming around the edges, sort of growing on top of the implant. We haven't had a single case of loosening or subsidence or any problem, really, breakage or anything. I think the fact that cartilage grows around the edges is an example of a compensated biological mechanism. The cartilage grows up. When it comes too far up, it's being worn away, and it keeps on coming. So it's a process that I think can go on for indefinitely, really. I have good hopes that this first patient that is now 11 years old may well become 22 years old in another 11 years.
Right, that's excellent. But any changes on any degenerative changes is something that we noticed following the insertion of the process? Any athletic changes? No, we don't see that, and that's another point, that we are paying a lot of attention on the opposing cartilage from our initial MRI investigation. We assess the opposing cartilage, and if that cartilage is too worn, we are talking about ICRS stage 1 or 2 being okay, 3 and 4 we get wary. So if the opposing cartilage is okay, we really don't see any changes in it. It holds up, and the follow-ups that we have do not show any degenerative changes or progressive wear or something like that. So we're quite confident, really, that if the preconditions are right, this is a long-term operation. Correct. And also the details to perform during the performance of the surgery itself, that having the osteotomy right, having the implant seated such that it's just at least a millimeter or two, a millimeter just underneath the surface.
Yes.
And that was some details that we had to focus on.
Yes.
And that plays a major role.
Yes, we don't want the implant to stick up, because that will carve away on the opposing cartilage, that is certainly a very important part of the operation, and that's why we have the epi guide, we call it, patient-specific guide that goes on to that particular cartilage piece of joint, condyle or talus or whatever, and it allows the implant to go in at exactly the right angle and exactly the right depth. And that's an important point, I think.
That's right.
So this patient is completed now 4 months post-surgery. Do you have any recommendation for rehab and follow-up?
4 months down the line, not really. I mean, just regular physiotherapy is good to regain muscle power, but the implant will grow and attach to bone in, let's say, 4 to 6 weeks. And once that is done, that's about the time it takes for the scar to heal and mature. The patient can do whatever he likes. So rehab is extremely short, really, relative in these types of operations.
Actually, I withheld the weight bearing for almost 6 weeks, so maybe a week longer, because the patient was not very keen. He was having some pain when he was standing. So that's the reason we waited for about 7 weeks to.
Well, there are individual variations, for sure.
Now he's been walking without a support. And I did follow him up. The 3-month follow-up was done. I filled out all the details, I think, the VAS score and all. So I'm sure I'm looking forward to long-term follow-up of this particular patient.
It should work nicely.
Thank you, Professor Leif, and thank you, Dr. Ajoy.
Thank you so much.